Welcome to Researcher Revealed. I'm Dr. Rosalind Austin, host of the podcast that goes beyond just the name that's listed on a paper or a conference proceeding in order to know a little bit more about the researcher who's done that work. On today's episode, I'm very honored to host Ben Bowers. He recently became an assistant professor at the University of Cambridge, and as a consultant community nurse, he's focused on palliative care, particularly around symptom alleviation in your final moments on Earth. I was really excited to dive into this conversation with him in order to get to know a little bit more about the level of complexity in the research that he does. So have a listen and see what we get to learn. Hi, and welcome to Researcher Revealed. I'm very excited and honored to welcome to this week's episode Associate Professor Ben Bowers. Can you introduce yourself, Ben? Tell us where you're from, what you do, what your clinical background is.
Thanks, Rosalind. So I'm Dr. Ben Bowers, and I'm an assistant professor of primary care with the Department of Public Health and Primary Care at the University of Cambridge. I'm a clinical academic community nurse is the best way I describe myself. I'm a nurse consultant in palliative care alongside leading a program of research, and I lead a team of 8 researchers across disciplines at the University of Cambridge. And one of my other titles is Deputy Theme Lead for the NIHR ARC East of England Palliative and Life Care theme. So I juggle the multiple hats, as many clinical academics do.
I was going to say, that sounds like a lot of balls you're juggling there, Ben.
It's all good fun. They merge.
Fair enough, fair enough. Right, so before we dive in, because I'm very excited to speak to you about your research, your role within community research, and in particular, I think, especially after the episode, I think it was a couple of episodes ago, I spoke to Stephanie Kirkland, and she does a lot of research around palliative care. So I'm very interested to have somebody else who similarly is interested in that unavoidable part of life. But before we get into it, it's time for the Researcher Rapid 11. Are you ready?
Go for it.
Are you a Windows or Mac user?
Mac, but I have to use Windows at work.
Ooh, interesting. Okay, so hybrid. Are you tea or coffee?
Tea, too much.
There's no such thing as too much tea, Ben.
It is when you go to the toilet too much. There's too much tea.
Oh no, there's no such thing. Oh my goodness, I've got 2 tea advent calendars on the go right now, and I'm currently like in the bathroom more than I am at my computer. Anyway, when you're writing, so doing some focused work, do you prefer to have music in the background, or does it need to be silent?
I'm quite dyslexic, so I actually really like noise. So I have a nice bit of music playing in the background, and I make my focused work in the morning when I'm most creative.
Nice, I like it. Very cool. Where do you tend to work, at home or in an office?
Well, as I alluded to in my two titles, I actually have 5 offices, so it depends on a given day. So this is my home base with a primary care unit, and I spend time here, but I also spend time at my college, where it's my thinking time. I also spend time in the Department of Engineering, so that's where I go to meet colleagues because I work across disciplines. And I do occasionally work at home. Basically, I work for where I'm most productive and then realize when I'm not productive anymore, I change setting.
Love it. 5 offices. That's brilliant. I think that's a record on the podcast. So you've answered the next question already. So most productive in the morning?
Yeah.
Yeah. All right, cool. This is the tricky question now, is what is your favorite referencing management system?
Oh, as a Zotero. I started with EndNote. All good makes accepted, but then when I was starting my PhD and I was writing up a paper as a systematic review, EndNote failed me spectacularly. So I went over to Zotero and don't regret it. So
Ooh, interesting. I've dabbled with Zotero, and I think the feature that I loved about Zotero is you can just copy and paste the URL in, and then it's like
It does
magic.
work.
And yeah, I love that about it. Because I've only done it on one paper so far, I probably need to go into it. I didn't figure out how to do like one of my favorite things that EndNote does, which is like you can put in the citation and it'll do like the number or whatever, but then you can change the format of it. So does Zotero do that?
It does. It doesn't take long to figure out how to do it, but you can change from Harvard to Vancouver, whichever format you want. Yeah. So
Oh, I might have to have you on
Zotero is
for
really,
like top
really good.
tips.
Yeah. Actually, to be honest, there's several which are really good. I think find the one you're most comfortable with, as you probably have too, Rosalind.
Yeah. Yeah. Well, I might have to go back to Zoltero because I know it. No, like you say, like it's good and it becomes like the choice of a lot of people. But despite it being around since like the cavemen period, it still has a tendency to throw hissy fits.
Yeah, it just has complete corruption
Yeah.
moments. Yeah. Yeah.
Yeah. And those hissy fits can be not fun.
No, no. I definitely wouldn't have wanted to be able to using that when I was writing my PhD and had to put 350 references in. I
Right.
would not have trusted it.
Yeah. Yeah. Fair enough. Interesting. I like it. Right. Out of that rabbit hole. What about your favorite data visualization tool?
I like Miro.
Okay,
Hmm.
nice,
Have you come across
nice.
Miro?
So somebody else mentioned it, and I had a look at it, and I think it looks good. But it hasn't replaced for me in my heart draw.io.
Okay, cool. Again, you learn tools and you get quite happy with it. For me, Miro, I was shown it by some engineering colleagues. I do a lot of
Ooh,
diagramming. It's a really
okay.
useful, clean tool for
Ah,
diagramming. But some of my
ah.
colleagues still love PowerPoint. They just go to the PowerPoint every time.
There's, I think it's like you say, there's different tools for different things. And I've started using a few other like open source things that require you to learn a little bit of coding, but not as much as R. So it kind of comes as like a separate little software program that you can input like numbers in or whatever. And some of those I find really powerful, but I still, like you say, I still end up and like taking them, putting them into PowerPoint in order to make them cool. Anyway, next question. Favorite desk snack?
Maybe the snack. Well, I have a half-eaten mince pie in front of me, which isn't my favorite because, frankly, it's 2 days old and not very nice, so it's half-eaten. Uh, I love a rich tea biscuit, but I know for my health, apples are better, hence one in the background.
Now, how long has the apple been there? Or should we not
Only,
ask that
only
question?
since yesterday because it was a Christmas do yesterday lunchtime.
Sure, good
Of
story
course.
then. Good story. Oh, perfect. When you're organizing or planning like a paper or project or your life, are you a digital planner or are you a pen and paper?
I hold it all in my head.
What?
Mm.
But how do you keep track of it all? How does it not like leave?
I did something. It's in it. I'm not. I'm a very visual person. I can see things visually in my head, so it works for me. Um, but in front of me is a nice big blackboard of projects and papers we're
Oh,
writing and
okay.
things. So
Okay.
some of the stuff I do visually. I'm a visual person.
Okay.
Yeah.
Nice. I like it. I like it. That's very cool. Right now for my favorite question is what book are you currently reading
Oh, what book am I currently reading? What book
or
should I be
listening to?
reading? Yeah, so I'm in between books. I'm just trying to think of the last book I read. I would look at my shelf. I think it was a bit worky,
Okay.
but actually the last book I've been reading was A Mortal Coil. The Mortal
Okay.
Coil was a very good read, actually. It's about
Okay.
public health and dying, but really
Yeah.
it's about public health and
Yeah.
disease, and so that was a work-related book. I have a stack of books to read at home, and I'm halfway through the second June book, and frankly, it's been sitting half read for a while now. So I've got a feeling I'm not going to go back to it.
Fair enough. There's no judgment here. There's no like, I just love books, and it's like my secret way of getting book recommendations.
Yeah, so this Mortal Coil, which is really about public health, we'll
Yeah,
recommend it
yeah.
as just, a really good book. Has a
Okay,
death framing, but it's also about how societies change and develop with health.
nice. Sounds very cool. That sounds really interesting. Right, last question before we get on to the good questions is who's a researcher who you admire?
Well, I've got several researchers I admire, so it depends what I'm looking for. So I'm going to give a shout out to, obviously, my mentors are amazing and incredible, and they're my mentors because I look up to them. So, from an engineering point of view, is John Clarkson, who's a systems engineer
Okay.
at Cambridge. My complete guru when it comes to medical sociology. So I cross disciplines. So the disciplines I talk
Hmm.
about now, I
Yeah.
sit in those fields. Is Christian Pollock, who's an emeritus professor now at Nottingham University, and working in Nottingham University's Ellie Wilson, who's an amazing social scientist. And
Okay.
I really look up to Ellie and like working with
Okay.
her. Um, and then from patient safety, I sit in patient safety too. Andrew Carson Stevens at Cardiff and Sarah Yardley at UCL, both are very good when it comes to patient safety.
Wow, that's quite the list. That's amazing.
And I'm going to put a shout out to one of my other mentors as well, Stephen Barclay, who's a professor of primary care, one of the first GPs to do a clinical academic pathway, and has been incredibly supportive, showing me what's possible and trusting in me and investing in me and seeing my potential, but
Mm.
also just being there as a sort of robust, critical friend when it comes to developing my research skills as a social scientist.
Wow. Oh, that's incredible. I just got goosebumps. I love hearing about like people's mentors and sort of like and I guess it brings me around to my first question is so nurse by background. How did you end up going from being a nurse to associate professor? Like, how did that happen?
Oh, I won't claim associate professor yet. Assistant professor.
Oh, assistant.
Yeah.
Sorry, wrong word. Sorry.
No. It's how did it happen? That's a really good question. Long story or short story? A short story. Um, so I was in clinical practice, and I was a district nurse, and my identity is a district nurse. Moved into palliative care, and I always love palliative care, and I always love asking questions. And if I'm going to be quite honest, I was a really good manager because I was really good at innovation and bringing teams with me, and we're working
Hmm.
together and empowering people. And I was a nightmare to manage because I was the one who was like, so, like, why are we doing this? Yeah, I get the policy says it. Can we not just change the policy? Because it doesn't make a lot of sense. And where's the evidence base? And actually, I jumped jobs probably every year or 2 years. So my friends take the mick of, like, historically, when we got married, one of the wedding questions was literally how many jobs has Ben had as a quiz. Uh, how many jobs has he had in his career? And frankly, it was far too many. So since 2017, I started my clinical academic career, and it's by far my longest post. And I think that's a reflection of the fact I found my feet and I found something which intellectually challenges me and
Yeah.
allows me to continue to grow and innovate. So to answer your question, how did I get there? I had an ARC fellowship, so an NIHR Applied Research Collaboration Fellowship.
Hmm.
And in 2017, I got one of those. They're competitive and they still do them. I highly recommend them. They're advertising now for most of the ARCs to start in April of 2026, and they do annual ARC call. And that gave me 1 day a week paid for, so my time was backfilled to my employer to learn how to do research and do my own research project. So as a specialist palliative care nurse, I had 1 day a week out where I worked with the University of Cambridge with Stephen Barclay, I mentioned. And I looked at anticipatory prescribing because all my research career has come from asking questions about practice. And I was interested about us putting the bag of drugs in people's homes for future event, which may or may not happen, for symptom control in the last days of life, a bag of injectable
Mm.
medications. And actually, I was putting them in the home and I was doing the, making sure they were in the home. And some of my conversations with patients made me reflect and go, actually, are they really reassured by this? Or am I reassuring myself and my colleagues? And that kind of made me
Interesting.
open up, where's the evidence base? So I did an art fellowship. Um, I didn't know at the time, but my mentor did know. I did a systematic review and an interview study. It was a big art fellowship, too big.
Wow.
I should have done one project. I did two. Uh, but, but yeah, there's a theme, by the way. So anyway, but the systematic review I did about the anticipatory prescribing evidence base allowed me
Yeah.
to identify great big gaps in the evidence. Now, my mentor knew that actually I needed to do that to then secure a highly competitive NIHR fellowship.
Yeah.
And he walked me down the path nice and gently.
Yeah.
And by doing that for that year, it made me feel more confident being a researcher, and I wasn't being, a complete usurper and basically a nurse can do research, totally can, and it's fun. Um, so that led to me then applying for an NIHR School for Primary Care Research PhD scholarship, which I secured and gave me 3 years out of clinical practice to do my PhD. Built up immediately more on the anticipatory prescribing evidence base, and I went and interviewed patients and families for the first time about their views of putting these drugs in place. And I also looked at records in a large scale way to understand what practice really is. Um, and yeah, I didn't look back. I won't bore you with more details. It's moved on to other things, and we can touch on those.
Yeah. That's perfect. What is it that, like, so in our short conversation already, you already struck me with like, you tend to do more than you should. You tend to do multiple things at once. You're not afraid to question status quo. We'll put it nicely instead of saying you're a troublemaker, but maybe a little bit of both. So what do you think it is about research that has given you that steadiness and that anchor now in your life?
Um, I think it's a creative space. I think as a clinical academic, there's something about so when you're with patients, you're doing your very best and you're constantly dealing with the now.
Yeah.
When you're doing research, you're thinking about the future as well. And I think there's something to be said about that. I think I look at research for nurses and AHPs and our medical colleagues as well. It's quite restorative. I think it's quite a good way to use a different part of your brain. It allows you
Yeah.
to then go, okay, I can step back a bit here. I'm not going to run at 100 miles an hour and I can just think more through things. I
Yeah.
don't think doing research is by any means easier. I would say I do a lot longer hours than I ever did. And I'm sure you're probably the same. But what it does is it allows you, you're owning it. You're generally very passionate about that.
Yeah.
You can be passionate about clinical practice as well, and I am, but actually it's the research component, which is a bit where I change practice,
Yeah.
really.
Yeah. I love that. I've never heard anybody say that before, and I definitely see that in me. That like being your clinical work or your clinical role is dealing with the now, where research allows you to deal with the future. We need that on a t-shirt.
The other thing we need is research is fun because actually it should be a fun process. I think
Oh
we
yeah.
learn a lot of training as a nurse, for example. You do research and you do research as a kind of thing which is theoretical, and I
Mm,
think quite often it's taught as a very theoretical thing, and
mm,
it doesn't feel lived. And actually, if you do hands-on research, you go, I'm having really good contacts with people here. I'm
yeah.
learning stuff, and
Yeah.
I'm involving my thinking as I go by.
Yeah. No, I agree. But now you're leading me to the next question because you just said research is fun. But Ben, you don't research a very fun topic.
No, it's true.
So,
Important, but not necessarily what people describe as fun.
well, and cards on the table here. Like, so everybody who's probably listened to this podcast already knows, like, I was trained in Canada, and I think I was very, very fortunate because at the time that I was doing my nursing training in Canada, the school that I went to, and you might have heard of this system, but at the time they had created and they were teaching all of their nursing students the family systems nursing model.
Okay.
And it was really through learning about that model, which was primarily built on, it wasn't a Canadian thing, but it was a Canadian researcher. It was primarily built on a lot of research around children who are dying. So really heavy, really hard subject. But at the same time, I'm so grateful for that training because it helped me to view death and dying differently, because it allowed you to be able to see, like, that as a clinician, as a nurse, you can really influence on that phase of somebody's life. And although it's sad, although it can be hard, although it can be dramatic and traumatic at times, you can also make it a powerful and beautiful event for the family. So, with that sort of context in mind, you talked a little bit in your journey of research about your interest being sparked by, like, why and how, what is the meaning behind leaving all of these injectable drugs in people's home during a palliative care session. So, what is it for you about doing research around palliative care in the community that really drew you?
I think, candidly, it's giving people a voice. I think we're quite paternalistic, generically, society as well as clinicians. And this, so when I use clinicians, by the way, in all contexts I say this, I mean
Mm-hmm.
clinicians as in anyone with healthcare training,
Mm-hmm.
because we are all clinicians. I
Mm-hmm.
think that's really important.
Yeah,
Um,
thank you for clarifying.
no worries. I get a little bit gnarled when people call medics clinicians and everybody
Yep.
else allied. Yeah, no, we're all
No,
clinicians. Um,
agreed. I'm with you.
but to answer your question, yeah, giving people a voice, I think actually is really important because at the end of life, we do a lot of people things with people's best interests to them, and I think we do them to them. And it's really interesting the recurrent things that people pick up in society about the livable care pathway, to a greater degree about assisted dying as well. I think
Mm-hmm.
people feel they haven't got much of a voice in this. And actually,
Mm.
my research tries to give people a voice back and actually
Yeah.
say what's important to you as a person who's dying, what's important to you as a family of somebody who's dying, and also what's important to you, the healthcare professionals providing that support. So
Okay.
trying to give people like a voice, and the Irish population that are dying of various things beyond cancer are really critically underserved, I feel. Their voice isn't there, and we kind of need to give people a voice so we can figure out what better looks like. So that's
Yeah.
what drives me. Um,
Okay.
and also just the fact that actually I don't think we should not talk about death and dying. I mean, it's part of our natural journey. And actually, if we don't talk about it, it's a unknown, potentially quite fearsome
Yeah.
part of life. Well,
Yeah.
actually, if we start to normalize death and dying, we can understand what normal dying, difficult term, what people's dying might look like,
Mm.
and also what can be provided and what help is available. And we can answer a lot of fears by having open
Mm.
conversations.
Okay. So I love that, like, giving people a voice. But as we all know, in order for our research to make an impact, it has to go beyond just you listening and interviewing these individuals. So, how do you then convert those conversations? And I'm guessing as well from reading a few of your papers in advance, some clinical data um, as well. So how do you manage to take these powerful conversations and convert them into something that can impact on the future people's care?
I think it's a really good question. Research is like showing a story in the same way as everything we do. So when we provide care, we're often providing what I would describe as narrative care in practice. We're attaining to somebody's story, we're supporting their story, and we're being part of their journey with them. In the same way as when you're presenting research, it's about presenting a coherent story which makes sense and quite often contradicts itself, the findings, because actually people contradict themselves. So people quite often simultaneously think one thing and another. And actually, it's unpicking that and understanding what kind of data you've got. So you touched on it, Rosalind, but I do qualitative work, I do mixed methods work, I do quantitative work. I do whatever research best answers a research question. And
Mm.
as when I was interviewed for my PhD by two of our senior professors in the department at Cambridge, they said, as a nurse, you're going to need to make sure you upskill for this and know all of these areas, because when you finish at the other end, people are going to look to you as one of the leading experts, and they were right. By default, PhD from the University of Cambridge, kind of clinical academic. So actually, it was really important that I upskilled in a broad range of methods. So I answer the question with the methods that both help, but I also always think, what is a coherent story going on here? And that's what the analysis, regardless of what it is generally getting us to. And
Okay.
I tend to drip feed with my papers. I tend to kind of, so if you look at my papers around anticipatory prescribing, you'll see that as time's gone by, my thinking's changed based on
Hmm.
the evidence I got. So
Yeah.
if you were to read one of my papers from now independently without the other work, you might think, oh, where's that coming from? It does
Mm.
stand up on its own, but I've been able to bring the evidence base with us, so most people are actually on the same page as we've learned more things about this particular area. I've been very lucky. I touched on an area of end-of-life care that hardly anyone had.
Well, I think luck is one word to use, but I think another thing that a lot of people who I've had as guests on this podcast, the more people I speak to about like who are clinicians who or who've had some sort of like an event in their life around health that has inspired them to do health research, is I think actually the truth of it, a lot of it is it's not just about luck. It's about having the openness that when you came across that canyon in the evidence, that you were in the right space, you had the right background in order to be like, I'm going to ask more questions here
Yeah,
instead of just plodding on, right?
yeah.
So I don't like the word luck.
We to some degree there is always I think an
Oh
element of that,
yes.
but I agree, we make our own opportunities, and research is a collaborative enterprise. So
Yeah.
Ashley is working with a team of people who've got your back and they're helping you develop, and likewise you're working together. A lot of my work now is supporting other researchers to do their own research as I progressively move into a leadership role.
Mm.
Um, but I'm also looking at diversifying my portfolio. So now I'm looking at workforce developments. I'm drawing very much on engineering techniques, and we haven't touched. I'm finishing my PhD. I applied for a Welcome Early Career Award, and I was actually successful. So my Early Career Award I have now. Thank you. First nurse to get one, so I was really pleased. And didn't think I would get one, but actually landed really well. And leading a program of work looking at how we can improve injectable medication symptom control care at home. And I'm using very innovative methods for health from different fields. And that's a lovely journey to go on.
So I think what I'd like to now focus on, because one of the things that's becoming very, very clear the longer we have a conversation is you kind of like complexity.
You got to embrace the complexity. If you
But I
can't,
don't think that's a unique thing for nurses. I think that's like one of nurses' most underrated skill sets is
yeah,
our ability to handle complexity. But I want to like narrow it down a little bit because there's two things that you keep kind of like coming out, and I think we need to define them a little bit better. And then also, like, maybe give some top tips around both of these things. So the first thing is you keep using the term interdisciplinary, cross-disciplinary. You're talking about engineering quite a lot. So what does that mean in terms of research?
Yeah, so they mean different things to different people. So for me, interdisciplinary research is where you work across fields and you go, actually, what in healthcare feels quite a unique thing in a different field. So we touch on engineering or patient safety. Actually, some of these methods are quite typically used in those fields. But in healthcare, we don't particularly use certain techniques. And it's
Okay.
going, what can I learn from working in another discipline to then apply to the discipline I'm originally from? And then part of that
Okay.
journey is to re-identify yourself because you, before you know it, if you start doing that, you truly become interdisciplinary because your skill set then bridges different dimensions. So
Okay.
I'll give a practical example. So we've been using
Yes.
patient journey methods. So patient journey methods in healthcare mean something different. You sit down and you work out, flows of patients. Actually, if you were really to use patient journey methods, you're not looking at care pathways, which is what often we do in healthcare, but call it patient journeys. You're actually looking at work as experienced and done from patients and families' views, which is actually quite different to workflows. And you can
Yeah.
then put it against a workflow and go, actually, if that's work as intended, we're going to do X, Y, and Z at this point. But the people's experiences can be dovetailed with that or can separate. And then you can use those methods to really understand the problem much better and then
Yeah.
start to find some solutions to complexity. So that's a practical example of using interdisciplinary work. Um,
Okay. So I really like that because I think a lot of other people I've spoken to talk about interdisciplinary instead of like necessarily pulling from like those skill sets, those methodologies. It's more like about the worldview of that individual and like pulling in like those different perspectives. But I think how you're using interdisciplinary is a bit closer to my own heart, where you're like, you know what, in nursing science, we don't have a thing for that, but in engineering science they do. So, hey, engineers, come
yeah,
be my best friend,
yeah.
show me how, teach me how, and then using that technique. Okay, so that's your interdisciplinary work.
And
The,
bouncing those ideas off people, if you don't mind me
yes,
adding as well. So
yeah,
actually just being in the same space as people. So you talked about my offices. There is a point to being in a different office because you get different exposure and need different
yeah,
conversations
yeah,
and sparks. And we have a college system at Cambridge, and you don't really understand the college system until later on. But the college system is really nice because you meet with different disciplines within your own college, and you're having meals together. So I was talking to a lovely chap who's a poet the other day about 16th century poetry. But actually, the key there was about narrative stories. So before we knew it, we were talking about narrative stories. You can immediately spark and take ideas one field and go, actually, we could do something with this. And it's those
yeah,
conversations and just bouncing your ideas off of people.
yeah,
So my mentors offer me a massive amount of support and guidance, but
yeah.
they also offer me an opportunity to bounce off equal like-minded people in different fields. What's
Okay.
going on? And that's just really useful.
Wow, that's very powerful.
So
Um,
my tip is for anyone who's listening who's a nurse or any discipline, work with people who aren't from your discipline as well as are in your discipline.
mm, totally agree. Totally agree. Okay, so that's the interdisciplinary bit. Now, having taken a quick squiz at some of your publications, one of the things that immediately struck me that being trained by Carl May and my PhD raised my bar for you.
I think you would.
Well, no, no, no. I didn't like. That did probably didn't come out right. So I was trained by Carl May, and Carl May, similar to it sounds like some of your PhD supervisors, he definitely. I use the word encouraged, but possibly it might have been a bit stronger than that. Requires, forces, cajoles. his PhD students to master, or well, not master, but use multiple different methods. And sometimes they can be within the same methodology, and other times they're not within the same methodology. And so when I'm looking at your list of articles, I'm like, we do more than just one thing.
Yeah,
Which is shouldn't be as unusual as what it is, but there you have it.
Yeah, right methods to answer the right question.
Yeah, exactly. So rather than like exploding about methods, because I've just looked at the time and I have no idea where the last 40, 50 minutes have gone, but the train has left the station. I'm going to pick one that has sparked my curiosity, because one of the PhD students in the project I've been working in Norway is using this method. And I've been sort of learning a bit through her, but I just wondered if you would be happy, because it's a method that isn't used that often. And in nursing science, we use a lot of focused groups and interviews and things like that, but they're usually like single point.
Mm-hmm.
But you do what's called longitudinal qualitative research. So can you just give a quick snapshot at what that looks like and how you use that tool to create the research you're doing?
Yeah, of course. So if you're doing sensitive research in any field, you want to have a relationship with a good relationship of trust built over time with people. If you're doing end of life care, especially as my particular speciality is to give people a voice who are in their last weeks and days of life.
Okay.
Now, actually finding the right time to have one-off interviews with people who are dying is very, very problematic, and their families. So actually, I use longitudinal methods, and I did it for my PhD, and I'm doing it for my welcome work currently. So there's a PhD paper called Simultaneously Reassuring and Unsettling, which I think we're going to add to the web link. So thank you. And that's a good example. So have a look at that one for the methods.
Okay.
But basically, the methodology is work on a patient case-based approach. So who's the patient or who the client who, in any sensitive research, who's at the center of a story? And then who's the actors in that story are important. So, for example, in my triads, quite often it's a patient and then the family caregiver. Now, one or both might take part, because the patient might give something of a voice of the patient, and certainly their own voice if someone's got dementia and they can't take part themselves.
Yeah.
Likewise, the patient might take part and not their family caregiver, or both. And I also then ask them, who's important in your care? And I interview those people who could be wider support networks, or they could be professionals. And to speak about your own supervisor, his work on burden of care, is a very good way to understand how burden of care is felt. Because you do interview points where you say, I'm going to interview you now, and then can we meet in about 2 months' time? Or if things change, phone me and I'll interview you sooner. And then you then follow up with sequential interviews. You start to hear people's narratives as things change. And part of that journey is actually people's perspectives change, but also people share with you different things as they get to know you.
Yeah.
And it's that sort of stranger in the train approach, and you start to get to know somebody, and then they're a bit more candid about their private accounts. They might share their public accounts freely, but private accounts start to come through. And actually, longitudinal work is amazingly good for getting really rich data over time, but you just need to think of it as different data. It's not a snapshot.
Okay. So your multiple data points then become standalone data points rather than like a comparison, like a before and after?
So it depends how you want to do the analysis. So I quite like thinking of everything in that case is a unit of analysis together.
Yeah.
So I tend to try and do a case-based approach, but you could equally say, well, actually, I can't analyze this data as cases because there's too much missing information in some of these cases. So I'm going to treat it as individual units, and a person and multiple interviews is one case. The next person in multiple interviews is the next case. A professional's opinion is another perspective. But by interviewing
Okay.
different people, you can triangulate accounts and you can understand what people take from the same experiences. They can take very different
Okay.
things. And that could be really useful. Or they can
Mm,
understand what someone else said very differently.
okay. Wow, that sounds really, really powerful. Um, so when you do the analysis then of these multiple interviews over time across multiple different voices, everybody from the patient themselves to anybody they identify as being important to their care, which I can imagine like that is could be quite complex in and
Yeah,
of
you have to
itself.
make sure it doesn't explode, basically, because this is really rich data you're collecting. So obviously, what
Yeah.
you don't need is oodles and oodles of interviews. So
Yeah.
you've always got to balance, how much data. I tend to use the concept of information power. When am I getting to a
Okay.
point where I'm getting such rich data that actually I'm not trying to present everything in the world. I'm trying to give a good insight, and I also use purposive sampling a lot.
Yeah. Yeah.
So I tend to do analysis alongside data collection.
Okay. Okay. So you have all of that data. Do you analyze it independently, or do you have like a team who helps you with that? Do you have any of your participants or like patient and public involvement help you with the analysis? How does the actual dealing with the data go?
So I best describe me as going through a transition. I'm a research leader now, increasingly, which means my days of leading analysis are like I'm always pained by this now. It's kind of finding the time to lead the analysis. So, for example, I haven't done until now, but I'm increasingly work as a collaborative analysis. So one of my
Okay.
team would take the lead in analysis, and I would do some second coding, and then
Okay.
maybe a different person from a different field. So Judy's currently doing an analysis of some of the longitudinal data we just collected. One of my research assistants, who's also a nurse, very, very
Hmm.
talented, and she's leading that analysis. And Christine, who's a medical sociologist, is having a look at some coding, and I'm having a look at some coding. And
Okay.
our views are informing Judy's coding going forward,
Yeah.
because then she just gets a different take on what people see from the data. And I also work with public contributors. So one of the other papers
Okay.
we share is a piece I did with public contributor Bella Madden. And it's an interpretive piece. It's completely off the wall, but it's actually Bella's quite a talented poet. And she helped
Oh,
me with coding some transcripts. And I said to Bella, actually, Bella, I don't want to researchify you. I would like you, if you're game, to think about what you've looked at now you've done the coding bit for us,
yeah.
and actually, as somebody who's got lived experience of caring for people, loved ones, very close loved ones at the end of life, what when you're reading patients and families transcripts, what are they invoking for you? And she's a talented poet. She was game and she's written in a poetry form, and it's an interpretive piece which we can share again. It's a very different way of thinking about what public contributors bring to the game. I think I wrote
Yeah.
in the piece because we added a reflective piece afterwards. And one thing for me is I needed to not be so paternalistic because actually I had more concerns about Bella's interpretation of the data and you know, sharing this with her and how she'd feel than she did. She was like, I'm really fascinated by this. But the other thing for me on the journey also is realizing different things. You do different things for different purposes. So if I did a traditional analysis, I'm doing it for the purpose of bringing out themes and overarching messaging. The piece Bella's done is about bringing out emotions
Yeah.
and the rawness of the experience of being a family
Yeah.
carer for someone you
Yeah.
love at the end of life. And they both do different things and they're both
Yeah.
very powerful in different ways.
Yeah. Wow, that's incredible. And what a great way to walk away from that paternalistic box ticking PPI activity and just like you said at the beginning of our conversation, I want to give people a voice.
Yeah.
And you've you've now facilitated that, but I think what an incredibly powerful extra dimension to your research work, because you can still present that traditional work, but if you have it tied to this much more personal, emotive account, I can only imagine the impact that that would have on the people who are reading it.
It's different powerfulness, and it's
Yeah.
interesting. I was talking to a colleague. I wouldn't have done that at the start of my career, Rosalind, because people would have gone, "That's all wacky, off the wall."
Yeah.
And but now I've kind of quite established in my field and quite
Mhm.
established as an academic. I've done
Mhm.
it, and people are going, "Oh, look, that's interesting.
Yeah.
Ben and team have done this." So actually, it's the right time for me to do that kind of work now.
Right.
Yeah. We just have to be
Interesting.
mindful, you have to establish yourself before you do some things which people might think are a little bit off the wall.
I'm not laughing at you. I'm more just laughing like I'm like, I could have used that advice a couple of years ago.
You
Shoot,
only
like that
learn by
ship has
doing.
sailed.
Only learn by doing.
Oh man. Okay. Um, so thank you for sharing that and like giving those snapshots. And like you alluded to as you were sort of discussing, everybody who's out there either listening or watching, definitely go into the episode description, wherever you're consuming this podcast, because we will link the papers that Ben was pointing to use as examples to kind of dive into like his research, his methods, and some of those things that he's just discussed. I think before we start to wrap up, I've got two more really quick questions. The first one is, what's next now?
What's next? Good question. Um, so I'm adjusting. I'm 4 months into my assistant professorship, so I'm adjusting to now leading quite a large program of work. So it's really the next year for me is about supporting the team to grow. We're having new researchers in the team getting to post. It's allowing supporting them to leave their research. And part of my leadership journey now is to enable others and get people bouncing off ideas with each other and doing really creative work. So that's the next bit for me. Research wise, I have some plans in the pipeline. There's a big grant about to go in. We just secured the NIHR ARC Palliative and Life Care um, theme for the next 5 years, which I'll be co-leading and then leading. Yeah, it's going to be a busy period, but I think a very creative period. And I think my benchmark is always actually what do I do? And I think value system is really important here. I always ask myself, I'll get involved if it helps improve patient care. And that's my benchmark. So everything I'm
Yeah.
doing next is how can we improve the care of people who are dying? And
Yeah.
if it isn't involved in that, I'd say I give a bit of advice or my thoughts, but I don't get involved because that's my focus is on improving
Okay.
eye care in the
Okay.
community and also increasingly capacity building. So
Yeah.
building the next generation of clinical academic researchers.
Nice. Excellent. Very cool. I'm trying to think, actually, I think you've already answered that last question that I was going to ask you is, actually, no, you haven't, because you alluded to it. So how do you, having gone on your journey from being community district nurse, and you were like, what about these injectables that you were leaving in people's homes, and you were curious as to whether or not they were actually benefiting the patient or whether they were making you feel better as a nurse, um, all the way up to where you are now. And you're starting now to think about like building research capacity in more nurses and healthcare professionals and clinicians, whoever they might be, in whatever um, identity that they claim as their own. So how do you do that? How do you build capacity?
Grassroots approach. I think something like this webinar is this podcast is lovely because it kind of brings alive what it is for both you and I to do this work, so people can go, actually, I can see other people doing it. But leading by showing is really important.
Mm.
I think we've spent years trying to build capacity in nursing research, and not done incredibly good, to be honest with you. Um, we have been quite radical. I've created and led after my PhD the Community Nursing Research Forum, partnering with the QICN. And over 3.5 years, we built a community of 1,100 strong community nurses, which is incredible. And like
Yeah.
so many gone on to do PhDs, have awarded their first grants, or just got more research active. And actually, it's bringing people together. I think the best thing to do in my career stage is to act as a conduit to connect people
Okay.
and to give people an opportunity to grow as well. So,
Mm.
and that's across disciplines. So I have in my team GP registrars, I have nurses, I have political geographers, I have a whole host of different people from different fields. And I think it's important that we work across fields. So my community nursing capacity building has been a very big part of my identity the last few years. And I feel that I've helped with the community working as a very inclusive community. We've really brought community nursing research forward. And I think we're now in a good place to build on that.
I love it. I love it. And I love your perspective on the way to build isn't to isolate, isn't to, only focus on nursing. It's actually to build a big community and to bounce those ideas off of one of each other, to share, to grow, to lean on a different profession who might be 3 steps ahead on method A, but maybe when it comes to method B, you're 3 steps ahead.
Exactly. It's quite often it's quid pro quo.
Yeah. So I really like that. Advice, the younger version of you. So they're out there right now, and maybe it isn't about injectables that are being left in a patient's home, but it's something else. What would you say to that person who's having that, oh my goodness, there's a canyon here where I thought there'd be a bridge when we're talking about the evidence gap? What would you give them for advice?
So this is going to be tailored advice for nurses.
Okay.
Firstly, do not consider that actually just because your manager says no, sorry, you can't go and do that, but that should be the end of it. Because I think quite often as nursing, so I started my research career quite 14 years after qualifying. I really wanted to start about 4 years afterwards, but I had a lot of people tell me, do your dues, do your dues, do your dues. So what I would say is be okay with questioning and
Mm.
make sure you build into your development plan, your professional development plan, the opportunity to do some research in some form. I'd suggest if you're really not research active to talk to your R&D department and
Mhm.
see is there options for you to get involved in something, which is
Mhm.
interesting. They often know of little projects.
Yeah.
Likewise, I would suggest reaching out to the people in the field that you're interested in, you're asking them for so what questions about who are the
Yeah.
people doing the really interesting work,
Yeah.
because you're like pushing an open door quite often. If you have a
Yep.
lot of credibility, don't you, as a clinician,
Yeah.
but be like, wow, you're a clinician, you're really interested in this.
Yeah.
And actually the other thing is to find a way to make sure that you keep your foot in what's real as you go through your
Mm.
career, whatever it takes to balance things,
Yeah.
what will work so you make sure that you're grounded in what's important.
Yeah. Oh, brilliant advice. Brilliant advice. Um, with that, I'm going to wrap it up. Thank you so much for being generous with your time and for joining me here on Researcher Revealed. Everybody who's out there listening, if you have a question for him, in the episode description, again, there'll be links where you can find him on social media. But the best way to make sure your question gets answered is drop it in the YouTube comment section, and then I can make sure that it gets answered. But other than that, until next time, I will see you all later. Don't go away. Up next, we have the top 3 takeaways from this week's podcast by Dr. Rosalind Austin. Insider information. Ben was suggested by a previous guest on the podcast And I'm so grateful for the suggestion. So if you're listening and there's a researcher out there who you really admire, that you'd like to hear more about, then drop me a comment, drop me a private message on social media, and I will do the heavy lifting. Ben Bowers was a fabulous guest, and I really enjoyed like diving into, yes, his journey, but I think the bit that was more interesting for me was around the methods that he uses and the collaborations that he builds, and how he's now reaching a stage in his research career where he's starting to do some really different things, still doing those standard methods, but starting to allow some creativity and some of his team members to flourish. So for me, my top takeaways. Number one, and this is going to be a bit controversial, is be a troublemaker. Listening to Ben, and I mean, he never disclosed the amount of jobs that he had before he landed in the clinical academic career pathway. But you know, he said himself, like, it was a standing joke among his friends and families of how quickly he was shifting jobs. And you could look at that as being like he was unsatisfied, maybe a bit of a troublemaker, because he was always asking questions, always challenging his managers. But actually, for him, that ended up being his superpower. And it ended up being his way that he skyrocketed into this research career. And I loved at the end of our conversations that he said, you know, if you are that person who's asking those questions, is don't necessarily hold on to somebody who says, oh, don't ask those questions, or you shouldn't be asking that, or do this. It's actually, you know, to ask those questions and to find people and surround yourself with those people that will see that as a good trait, as something that can be developed, as something that can help you in your career grow. Yeah, be a troublemaker. My second top takeaway is to borrow expertise. So he talked a lot about this term of interdisciplinary, and I've also heard the term intersectoral being used as well, but where you build a proper collaborative team around you, and that team isn't just people all from the exact same discipline, so nurses, or even from the exact same field of expertise. So, you know, in Ben's case, palliative care. It's actually, you can start to really power up the research that you use, the methods that you use, if you start to borrow and build expertise by making the group around you full of lots of different disciplines, whether that's, you know, medical doctors, whether that's like in Ben's case, engineers, whether that's patient public involvement, whether that's like other stakeholder groups, whether that's whoever is right for the project. He kept saying this throughout our conversation. Do the right thing, use the right method, get the right people in order to answer that question. So I think, yeah, my second takeaway is, in order to enable you to do that, is borrow expertise. My third takeaway kind of combines being a troublemaker with borrow the expertise. And it was near the end of the episode that we started to talk about this. And I think, like, to sum it up, is utilize your resources. So Ben shared that, you know, there was a period of his life where he was bouncing around from job to job. And then he got given this opportunity through the NIHR schemes, their ARC schemes and fellowships. And that kind of started to change his direction and change his life in a way as well, because he's managed to stay in that career pathway, that trajectory of being a clinical academic researcher, to the point now that he's starting to become a much more senior research leader. But he didn't do it alone. And it's not just about the long list of mentors that he listed, which is a great resource for anybody who's listening to this as part of the researcher revealed rapid 11 questions. But it's also about, like, understanding that the NIHR is out there, that there are internships, there are fellowships, there are funding schemes that you can apply for. And I think it's about using those resources and reaching out to, whether it's people that have been guests on this podcast or whether it's people within your own trust, in order to start to build and embed research in whatever format within your career as a health professional, an engineer, or whoever you are listening to this, around health research. So I think, yeah, utilize your existing resources. Right, that's it for this week. As always, if you could, leave a like, do a review on a podcasting platform, drop a comment on YouTube. Anything you can to show me that you're out there and you're listening is greatly appreciated by me. I will hopefully drop the next episode in about 3 weeks. So until then, keep asking why.